Good morning, everyone. Everyone awake? Yeah? All right, so you got one up on me. So welcome to SAEM, and thank you for coming to our workshop this early in the morning on the first day. We're very excited to have you here. Part of this is because this started out as an idea for our fellowship projects for Stacey and I. And the way this project was born was just thinking about what more can we do to improve inclusivity in our work environments. And whenever, we've all heard a lot about diversity, equity, inclusion over the last few years, and everyone talks about what it looks like. It looks like diversity, it looks like recruitment, but what does it actually feel like to work in a work environment that is inclusive and fair and equitable, where everyone feels that they are empowered to succeed? And that brought me to the question, well, how do we create a culture change in our work environment? And culture change comes from behavior change, which is very difficult because we're all adults. And that's why we decided to start with that most basic of workplace equity issues, which is, well, microaggressions. They come from a place of implicit bias, unconscious bias. And to get people to change, we have to get them to understand that we just all have to be really open to learning. And that is how this workshop was born. So we're very happy to have you here.
Check, check, 1, 2.
You can hear me, right?
Check 1, 2, check 1, 2. Hey, 2, 1, 2. Check, check 1, 2.
Awesome.
Hey, 2, 1, 2. Check 1, 2. Test, test. Hey, check 1, 2. Test, test. Hey, 2, 1, 2. Check, check.
I think it is working. Somebody let them know.
Yeah, it's very, very much. It's overworking. So we have a powerhouse of speakers and facilitators today. We're really excited to have them all here. We're privileged to have them. Some of them have been our own mentors, our program directors. If you just want to go around the room and introduce yourselves in alphabetical order, Alay is over there.
It's working.
Yeah, you could.
No Vonzella A.
I'm Melanie Cheng.
Just all the facilitators, can you introduce yourselves? Arlene. I'm Smruti. I'm some faculty at MIMO.
I'm Stacey Frisch, also at MIMO.
I'm Sreeja Natesan.
I'm Mukul. I'm from MIMO as well. I'm David. I'm also from MIMO.
Teresa from downstate.
Awesome. I'm going to give it up to my colleague, Stacey Frisch.
I don't like the podium, but is this working? No, right?
Actually, can I borrow those for
Is
a
this
second?
one? No. Okay, that's fine. I don't hear anything. Can you all hear me?
Yeah.
Okay. Let me know if it's too quiet or anything. So I want to share a story with you that was one of the things that got me sort of thinking about this topic really early in my training. When I was an intern, I was working at Kings County Hospital, and I remember vividly this patient scenario. I had an older gentleman who came in with some sort of cardiac issue. Honestly, I don't remember what it was. He was in a room that I distinctly remember exactly where he was, and I was treating him, and I had called the cardiology consult. So in walks the cardiology fellow with me, because I'm there trying to learn intern year. I was, really don't know very much of anything. The cardiology fellow that comes with me is a tall white male, and he's wearing a long white coat and, somewhat like what we would consider typical professional attire. The patient was engaging with us, and he was calling me miss, and he was calling the cardiology fellow doctor. And I don't even think that I really realized it at the time. I think that I was so focused on treating the patient, figuring out what was wrong with him, learning about whatever it was that was wrong with him, that I'm not even sure that it occurred to me until the cardiology fellow said to the patient, this is your doctor, you can call her doctor also. And that was so powerful to me. And I had a lot of thoughts, in the moment and even afterward. I was thinking about, initially I thought, well, why didn't I notice that? Like, why didn't I respond? And some of that may be because this type of thing happens frequently, and some of that may be because of all of the distractions. But the fact that the cardiology fellow, who was the bystander in this situation, was there and was an ally to me in that moment was so, so powerful to me. And I also feel like there was some component of, like, should I have responded? And that's not really fair on myself in that kind of a situation, or really to any recipient of a microaggression awesome session planned for you today. I'll hand it back to Smruti.
So we did a lot of research before we created this workshop a year ago. We initially created it for our own faculty and residents at our institution. And I looked up a lot of different trainings that had taken place all over the country. And they often focus on the recipient, giving the recipient the tools to respond and getting the recipient to figure out how they want to engage the source. However, it feels like, it feels like an unnecessary burden on the recipient who has to keep doing their job, just like Dr. Frisch was talking about, to figure out whether that was really even a microaggression. Do I respond to it? Is this person my boss? How do I deal with it? And we want to shift the focus to creating better allyship and also getting people to recognize when they're a source of a microaggression, because any of us can be a source of a microaggression, and recognizing our own implicit biases and using apology as a learning tool and not a blaming tool. And so our learning objectives are all focused on that principle, on how can we be better allies, and how can we also recognize when we are a source ourselves, and how can we learn something from the experience. I'm going to give it over to Dr. Natesan.
Hey guys, I'm super short, so I'll probably just stand on the side so you can actually see me over here. But before we jump into our agenda, I think it's probably good, in this kind of session to have a kind of moment to pause and talk about some of the ground rules, because this is a very kind of challenging topic, and it also can make us feel very vulnerable. So I want to kind of invite you into this space to kind of be engaged and learn together. And I would say, all of us as facilitators, we're still learning, which is why we're going to be participating in each other's session as well, because this work is never done. And the more you learn, the more you realize there still is so much to be learned. And even just, we were talking right before the session, sometimes even recognizing it, we don't recognize it until after this happens in our workplace. And then we think about a lot, all of the what ifs, or why didn't I recognize that? And so really it's important to, have, as my friend LA always says, self-compassion on ourselves, and then also just use it as a learning point to kind of bounce off. So a few of the ground rules that when I've ran these sessions kind of institutionally and at some other conferences, one is just be respectful, seek with curiosity what each other has to say, right? We'll talk a little bit more, Dr. Bryant will tell us a little bit more about impact versus intention, and just be thoughtful about our words have power, but we also want to kind of seek with curiosity how we can learn and grow from each other. I think all of us have our own lived experiences that will really make this session this morning really valuable for all of us. Second is that, I like to use the word brave space. I'm a natural introvert myself. And so, instead of a safe space, it takes a lot of bravery and courage to step in, and also caffeine and coffee, to step into the space and participate. So we definitely want you to all be engaged in that. And then kind of finally, just, there's something in DI that I learned going through a teaching for equity fellowship. And they usually say, the stories stay here, but the lessons leave. So if it's someone else's story that they're sharing with you in this vulnerable environment, just let that story, it's their story, so let them be able to share it. But you can take the lessons that you learned from that story out of this room, just so that we can create the confidentiality that we need to be vulnerable in front of each other. So any other thoughts on any other ground rules that you guys have used in having these conversations? Perfect. So this is kind of our lay of the land. So we're doing our introductions. Check. Doing great. Dr. Bryant, I'll do an introduction in just a second. And then we'll do actually putting the words into action, so our response training. And then finally, we'll let you guys have a little break to try to track down some coffee, which is very challenging. So it might take more than 15 minutes, but you can try and let us know if you're successful with that. And then for the second part of the morning, we're actually going to do some micro lectures, idea generation, and actually some practice as well, too, from 11 to 11:45. And then we'll wrap it up. Likely we'll try to get you out a little bit early as well for the section. So with that, I'm going to look at my notes because Dr. Bryant is so amazing that I do not want to miss any part of this. But Dr. Vonzella Bryant, I met several years ago actually doing actually it was during the pandemic. I think we started working together doing an online virtual conference together on microaggressions. So I've been very thankful to learn from her. But she's an assistant professor and the assistant Dean of Student Affairs at Boston University. She's worked as an attending for the past 20 years and does multiple lectures both institutionally and nationally on diversity in the field, as well as healthcare equity. She also serves as the liaison in her institution for her JEDI group, so Justice, Equity, Diversity, and Inclusion, and also is really passionate about recruitment of underrepresented in medicine interns. And they've actually been able to, in the last 4 years, grow their representation from 10% to 21%, as well as over 65% are females as well, too, which is really incredible. And she's led these microaggression talks at her institution, including both nurses, techs, basically our whole team, which you'll see is really important. That might be the call of action that we'll be asking you guys, is, we will learn this, and to be fair, in the room, we are the ones in this weird hierarchy of medicine that has the power to speak, but we want to have our whole team feel powerful to be able to speak up, and so that's why it's really important to kind of engage your whole team. And then one last thing is, Dr. Bryant is really amazing in so many ways, but she actually was recognized by the U.S. News World Report as one of the hospital heroes during the pandemic. So that's alongside Dr. Fauci and Dr. Gupta and many others. So definitely I want to say congratulations to that. And then also Heroes of the Match for the New England Celtics as well, too. So just so many different accolades and awards that are so well-deserved, because she's been serving our community for decades. And so we're really thankful to have you here, and I'm excited to have you take over.
Good morning, everyone. And I'm so grateful to be here, one, because there were so many flight delays yesterday to the point where they were like, you're not going to make it there till 10:30 in the morning. I'm like, but I'm supposed to be talking at 8 a.m. But then I'm just so excited to see you all in the room with us this morning, even with the lack of coffee in some of you all. But I'm excited that you all are here just to join us in this conversation. Let's see. First, I want to say that I don't have any disclosures. And the learning objectives, we're going to define and recognize implicit bias, identify and reflect on how implicit bias affects our medical management, review foundational knowledge on microaggressions. Now, how many of you all out there have taken the Harvard Implicit Association tests? Yeah, and some of us have taken it a couple of times, which is a good thing, just to see where your temperature is. But I feel like I don't really need to review what the definition of implicit bias is, but this is the Merriam-Webster dictionary definition: a bias or prejudice that is present but not consciously held or recognized. And what that sounds like to me, is that you're judging a book by its cover, which a lot of times, or our parents, they told us that's not a good thing to do. And unfortunately, in emergency medicine, we have tons of evidence of having bias with our patient management, from pain management to the choice of radiographic studies, to our severity scores and triage, to our management of mental health patients, to the effect of the people that we restrain. Houston, there is a problem. Oh, I knew I wasn't going to land that right. Houston, we have a problem. Even though I know we're in Austin and emergency medicine, we have a huge problem in bias. And actually, when you think about it, if we have a problem with bias with our patient management care, just think about how that also bleeds on to our bias with our colleagues and our trainees. One of my colleagues, Dr. Jolien McGreevy, he actually had a paper that came out a couple of years ago about diversity pipelines and the rationale to recruit and support minority physicians. And I felt like this sentence here was just super, super powerful. Actually, it doesn't include the whole thing, but he's mainly talking about how institutions fighting a habit, and the habit that he's talking about is bias. And he says that although physicians might benefit from finite implicit bias training programs and succeed in translating what they learned about their own limitations and misperceptions into more enlightened patient care interactions, they are more likely to derive lasting benefit from daily exposure to diverse colleagues who shape their habits in unanticipated ways. I just want to say that last part one more time. They will derive lasting benefit from daily exposure to diverse colleagues. And so we're not just talking about having diverse unit coordinators, diverse transporters, or nurse assistants. We're talking about actually diverse colleagues and trainees. And so it's important for us all to be active in trying to make a more diverse workforce. But then when we have that diverse workforce, we want to make, see, that was the top of it. But we want to make sure that they are supported. Oh, this wink wink here is that, says that having a diverse workforce is longer lasting than our DEI workshops. But I'm super glad, or we are all super glad that you all came out here today, this morning. But having this diverse workforce, we need to be supportive. And the way that we're going to be talking about that today is addressing microaggression and allyship. But then you're going to find that being more supportive for diverse workforce is going to actually help all of us. And I'll talk about that a little bit more later. But let's go back to defining or describing what a microaggression is. And according to Dr. Daryl Wing Sue, he describes it as the everyday slights, indignities, put-downs, and insults that people of color, women, LGBTQ populations, or those who are marginalized experience in their day-to-day interactions with people. They happen casually, frequently, and often without any harm intended. Often without any harm intended. That's what makes it so micro. And you're like, I guess it wasn't a big deal because it wasn't in your face. Now, most of us have experienced firsthand or secondhand, the context of race and gender as being the context for a microaggression. But we also have to recognize that everyone can have a microaggression. It could be our sexuality, it could be ableism, it could be ageism, and I'm saying that right now with my eyes going bad these days, especially with procedures, but then also religion. So all of it, microaggressions can affect all of our professional and educational experiences. So I'm going to read off some scenarios, and I kind of like to get some nods or some if you have heard something similar. So nurse looking for a resident. Yeah, I'm looking for that little girl with the gay pride button. Or resident to a nurse discussing patient's family. That family keeps insisting that they are expecting a miracle from God. They are completely out of touch with reality. Nurse to a resident. I wish these people would stop leeching off the system and get jobs. And this kind of stands out for me because we do have colleagues and trainees that came up from backgrounds where there was houselessness, and also they came up as immigrants. So we have to take this at heart. Security guard to a Black medical student. Do you work here? Can you show me your ID? Actually, this happened to me a couple of days ago at work, and I feel like I'm not telling any patient or privacy stuff, but yeah, I took or at least I felt like took such great care of this patient with a mild asthma exacerbation, but then also she had a lot of social needs that needed to be covered. I'm up here calling social work, I'm calling shelters, I'm just doing all this stuff. And then when I'm like, okay, I'm ready to discharge you, and she's like, well, I haven't even seen a doctor yet. Even though from minute one, hi, I'm Dr. Bryant, and this is my nurse colleague. And even our badges say doctor, D-O-C-T-O-R, instead of M-D. So it happens. But the thing is, like Dr. Sue said, often without the intent of harm, but as they say, death by 1,000 paper cuts. And these paper cuts can trigger anger, depression, and also can even lead to substance use disorder. And also, it can erode confidence. How many of y'all know anybody, and it could be yourself even, who have felt like their confidence has been eroded? I mean, any of y'all know any folks that you work with, trainees? Yeah. Now, there is that thing called imposter syndrome or imposter phenomenon. I mean, a lot of successful people have that where they don't feel as if they achieved what or didn't deserve to achieve what they achieved. But then, imposter phenomenon is there's high rates among people from underrepresented groups, but then also for women. And just like it was stated earlier, we got to stop trying to make the person that are feeling these things try to like own up or change. We should change the culture, and that's what we're all here for. Also, it can lower, or microaggressions can lower your productivity and also affect your problem-solving skills. So it's a bad thing. So we're here to try to figure out what we can do to make it better. I'm going to go over some scenarios as far as the intent not equaling the impact. So, wow, you're so well-spoken. And the intent, or what they may have meant, was like, I'm giving you a compliment. But then the impact, or what a person may hear, is that I don't expect people of your race to be so well-spoken, or people of your race normally aren't well-spoken. Another one, you don't look like you speak Spanish. What they may have meant, I'm curious about your background. I couldn't tell what your race or your ethnicity was. But then the impact is that Spanish speakers are usually dark complexioned, or those from a Latinx background, they all kind of look the same. Or that one question, where are you from? Where are you really from? Of which, again, the intent may have been, I'm just curious, but it makes someone feel as if they're not American. This slide kind of messed up a little bit, but I don't know how many of y'all had that question, where did you go to medical school? Of which, again, it was probably super innocent, maybe, but they may have just been curious. But then to some those who are from underrepresented groups or are women, it's kind of like, are you really qualified to be my doctor? And then the comment, Anita, did you pass off the patient in room 6? Anita, Farah. And the intent may have been, I forgot her name. She hasn't rotated here for a while. Their names are similar. It takes a while to learn the residents' names. It was an honest mistake. And I loved how we opened up saying that even ourselves could be the offender or the person who has said the microaggressions, because I definitely have caught myself doing this. But then the impact is that you are interchangeable. I haven't taken the time to commit your name to memory, and I have learned your white colleagues' names, but not yours. So some of the themes of microaggressions, according to Dr. Sue, are outsider. You speak English so well. Well, even though you were born here, but it just definitely makes you feel like you're other, that you're not American. Also criminal. Please show your ID when no one else was asked to show their ID. Also competency. So called by the first name, of which, if everyone agrees on a panel to be called by their first name, fine. But then if only one person's called by their first name and everyone else is called Dr. So-and-so, not cool. Or even being asked to take notes in a meeting when you're the only woman. And then center, teasing, hinting that your identity, for example, religion or sexual orientation, is inherently sinful. Boop, boop. There we go. So I talked about how there's well-documented bias in the care of our patients. But then there's also well-documentation of microaggressions among our colleagues and our trainees and the effects of microaggressions. But I'm glad that we're all here today to look for solutions, or maybe not solutions, but strategies. And at Boston University School of Medicine or at Boston Medical Center, during a mid-career faculty leadership development program, we came up with the LIFT tool, in which I'm not going to go into all the parts because we're going to get into it a lot more later on. But the thing is, we want to think of strategies that are going to call people in instead of calling people out. Because if we call people out, or I'm going to say it, the cancel culture, which that's so inflammatory. But the thing is, once you call people out, their minds close down and they stay fixed. So we need to find ways of calling people in so that we can celebrate growth mindset, and then we can have a culture where everyone is growing and learning together. Lastly, I'm just going to talk about being an ally. I just love that I found this from the LEAP framework from Wharton. How you want to listen and learn from others' experiences. How many of y'all heard of gaslighting? Which I've been using gaslighting lately. That's sounded hip and cool. Like I had a patient who, she had a needle stick and it was minor in my head. But, for my patient to say, oh, yeah, and the nurse manager up there said, it's not a big deal. I was like, ooh, did she try to gaslight you to make you feel like this wasn't a serious thing? We are not going to do that. But listen and learn from others' experiences, especially if you're a leader, when you can actually do something about it. Engage in racially diverse and more casual settings. So like I said, I'm coming from Boston. How many of y'all knew that Boston was 25% Black? 1 in 4 people in Boston are Black, which, when you watch TV and you look at movies, you don't see that. But I say that because there's a lot of nice pop-up restaurants in Boston that are Black-owned, and even a speakeasy, which is fantastic and great. But, just find, go outside comfort zones and go to these areas, and it goes a long way to develop relationships. And then ask about work and goals, but then provide opportunities, encouragement, and support. Again, being an ally is making people feel very valued. And so I'm going to end with this slide here, dream, plan, and act. And what this means is I want you to remember intentionality. Like, things aren't going to change if we don't do anything to create that change. But then also be welcoming and inviting. And so we talk about diversity is like inviting people to the party, but inclusion is asking them to dance. Thank you.
Thank you, Dr. Bryant. That was very enlightening. And even though we've been talking about this topic for a year, it was just so great to hear you talk about it and have our own takeaways as well. So next, sorry.
Teamwork. Thank you so much, Dr. Bryant. That was amazing, and I think that's a great foundation for us to kind of, in this next part, we're going to do, kind of a call to action, right? Let's put what we've learned, kind of this foundation, and practices together in a brave, safe space where we can actually really kind of put those skills and kind of solidify them a little bit more. And we'll give you some more things to put in your toolkit, because you'll see each of us carry our own personalities and the way that we interact with the world. And so what works for one person may not work for another person. So really figure out, how are you going to react into these situations? And so that's why we're going to do a little bit of a training course for the next hour or so, just to really go through a couple scenarios and really work together on this. And so I think you guys have met us as the developers, so we'll kind of skip this a little bit, but we're really excited to just do all of this together.
So has anyone heard about the microaggressions triangle model or read about it? You have? Yeah. And I like this model a lot because, like Dr. Bryant was saying, right, when we talk about being the source of a microaggression, which we're all capable of, it's very easy to shut down, feel defensive, and kind of even sink your heels even deeper into the sand. And this triangle model sort of it encourages us as facilitators, us as faculty who want to train other faculty and residents, to encourage our learners to look at the perspectives of each person on this triangle. Again, sort of, echoing Dr. Bryant's table with intention versus impact. If you think about the perspective of the source, they may feel defensive, they may feel that, I'm gonna be seen as racist or sexist, and I need to do everything to undo that, and then they over-explain, and then they totally miss the point. As a recipient, you have to think about, well, what does this mean? Should I say something? Should I not say something? I'm frustrated. I also am a doctor and have to continue resuscitating this patient, and I don't want to get fired. I don't want to be seen as oversensitive. And as an ally, as a bystander, which arguably is probably something that we all find ourselves in pretty often without maybe even recognizing it. You think, if I say something, am I going to make it worse for the recipient? Should I say something? What if I'm stepping on some toes? Did I even recognize the microaggression? And so it encourages you to think about each person as a human being who is in this environment where they're either making an error without realizing it, and I think it just kind of helps us understand what each person on the triangle can do. From the perspective of the source, again, echoing Dr. Bryant, engaging with your diverse colleagues, placing yourself out of your comfort zone, making authentic relationships with people who are different from you. Also taking your learning points and passing them on to somebody else. So if you find yourself as a source of a microaggression, which I have definitely found myself as well, kind of going forward and saying, hey, I made this mistake, and just kind of what I learned from it. Other things, and then in the future, continuing to advocate for people who are different from you is very important. And similar concept with the bystander too. Continue to advocate behind closed doors. Just because you couldn't say something in the moment doesn't mean that you can't say something later. And continuing to provide mentorship and sponsorship, and just in all continuing to learn.
So I want to take a few minutes to crowdsource from you all about times when you've been a bystander before and what encouraged you to speak up or what discouraged you from speaking up. So just try to think in your mind about maybe some recent times or something that stick out in your mind when you were a bystander or witness to a microaggression, and did you respond or did you not respond? I'll tell you that there have been many times when I've been witness that I did not respond, and so I want everybody to feel free to share like why you may respond or why you may not respond. So I guess we can kind of go around and if you have any ideas.
I was brought up in the Upper East Side of Manhattan, liberal Jewish family, and taught from a very early age to be colorblind. And sounded good. Seemed to make a lot of sense. But a total failure as a social construct. It was based on the assumption that racism, for instance, was this passive thing. As we all got better educated and more sophisticated, it would just sort of fade away. And that, total lack of recognition for the cancer that it is. So I think anybody, especially with significant gray hair, grew up in that environment, bystander, without interaction to, I don't even know what the numbers are, just a huge number of these kind of microaggressions. This what seemed like a sensible approach at the time, but it just proved to be wrong.
Thank you for sharing that. Anyone else?
I have some instances where, so I grew up in a conservative family, Midwest, and growing up, I would hear my parents have different discussions, and as I got older and became more educated, surrounded by a more diverse environment, because I grew up in like a predominantly white town, went to private Catholic schools where there was maybe one or two minority in my class or in the entire school. And so as I got older and come home and my parents would be watching the news, they would make some comments, and early on I didn't feel like it was my place to say anything because they're your parents. Like, who are you to tell them that they're wrong? But as I've gotten older, I've gotten more comfortable with calling out, like, hey, that's not really what you're supposed to say, or like, let's talk about this, let's have a discussion, let's see if I can maybe widen your worldview for a change. So that's kind of been my perspective outside of the professional environment.
That's really great, and that touches a little bit also on just the culture that was ingrained in you growing up, and even a lot of that, like you were both speaking about it very consciously, thinking about it, but a lot of that might be subconscious for many people as well. And the other things that you are mentioning, I would think like somewhat fall under the hierarchy structure. Like who are you going to be speaking up to? Is it going to be your parents? You feel like you don't want to disappoint them, you don't want to get in trouble with them. And similarly in the workplace, you have those people also, right? Like your bosses, or maybe somebody that's going to be putting you up for promotion or not putting you up for promotion, or something like that. So that's really important.
I think that it's really tough to know when people know certain things. Like just in the last lecture, the question, where are you from? You know, to me, if they ask me that question, I just answer, and you know, it can mean many different things. What's your ethnicity? Where do you live? Where did you work previously? But it's just not a specific. It's a very open-ended question, but to other people that may conjure up a lot of feelings of insecurity. And so, as a or just not know, like feeling they don't belong and not feeling included. But when you're a bystander, you don't know how the person is taking that question. So it's tough in those circumstances to know when you need to intervene, and was that something that was making that person not feel included. That's a challenge.
Right, like having a different perspective or having a different idea about the impact of whatever it was that was said, that's certainly a challenge. I think we're going to get to this a little bit later in terms of response strategies for being an ally, but one of the response strategies that may fit a scenario like that would be to offer like a later discussion about it. So, you know, you could pull aside the person that might be a recipient, just check in, see how they're doing. Maybe they didn't feel like it had a negative impact on them, or maybe they did, and then you do have a chance, you know, to address it later even if you're not sure in the moment. There was an
Yeah, I have an example from a clinical setting. There's a teaching team that's part of one of our sides where they primarily teaching residents, and I was working by myself, just seeing patients on my own, and the attending and seeing a patient, and then the resident was presenting and kind of used the term total body galore, which I'm sure you guys know is kind of problematic term, taking stereotypes versus sex patient, and minimizing their discomfort and their adverse state in the emergency department. I think normally I find a lot of difficulty making a comment that sometimes it's not my place, sometimes it's not my resident. It's hard to feel like you can step into those shoes, but honestly, because of this training, I felt like I had the responsibility and privilege to be able to hopefully correct that term. So I told the resident, you be really careful about using that term. It's a loaded term with a lot of stereotypes behind it that are not necessarily fair for the patient. And afterwards, the attending actually pulled me aside and thanked me. Thank you for teaching that resident. They're in a state where they're able to learn and willing to learn. So it was useful feedback for me, as well as it was a good example of being able to use training in real life.
Great.
I'll share something that I recently screwed up on. I was, and you know, I'm very comfortable with my screw-ups. I was in this late learning session Thursday night after like a full day meeting, and so clearly none of us had our cameras on in this Zoom meeting, learning how to like write a paper. And somebody was raising their hands, and they just kept on getting ignored. At least that's what I perceived. And so I sent a direct message to the speaker, who I guess I also didn't consider the fact that it's been a long day, and they're just trying their best to give us this 1-hour lecture at 8 p.m. And I visibly could see how it threw her off, because she felt bad about it. And then I also direct message that other person. I was like, no, other people just are speaking up. You can just speak up if you want, instead of keep on raising your hands. And I guess what I'm trying to say is I was overlaying my upstandering role when in fact I was disrupting the talk. And the other aspect of this, I realized later on that that person kept raising their hand in prior sessions with this one person, and so they had their history, which I completely had no idea. And so I guess what I'm trying to say is there's a lot of self-compassion. I practice. I'll say, you know what, I'll try my best. And also I reached out to the speaker later on and in some ways like apologized for like, I as much as we can come at it with good intentions, it can also fall short with the actual impact of creating a space that is inclusive.
Thank you for sharing that. Yeah, and I think that brings up two kind of topics. One of them that you don't have the background necessarily of the relationship between, the source and the recipient. And you may not know, the backstory and that this person had been maybe oversharing or raising their hand a lot in some other session, I don't know. And also time. Like, I'll tell you, just this past week, there was a situation when I was working in our critical care area, and there was some charge nurse who was talking to a different charge nurse in the other area and said something about her being short, and she responded with humor saying something like, yeah, I couldn't reach the note phone because of my T-Rex arms. And I felt a little bit bad about the whole situation. It was just like a weird comment, and I wanted to say something, but I also had a crowd of 40 people around a patient that was dying, and I had a woman that was like, with mixed coma that I didn't diagnose, and I had a guy in my crisis, and I just had no time. I was just like buzzing between places. And so time is also, either your time and the time of the situation, or maybe the time of somebody else's talk, or that sort of thing. Yeah, it's real. Second question?
Yeah, so there will be instances where a patient, or there's this one incident that burns my brain, where a patient at another hospital, BMC, my boss is here, even though it happens at BMC too, but my resident has a Middle Eastern background, and the patient was like, I don't want him taking care of me. And I learned the script of saying, is there to question, ask more questions, not say it's because he's a Middle Eastern background, but why is it, blah, blah, but just saying that this resident is my value, he is very valued by everyone here, and he's gonna give you the best care, and I'll be in the background, but no, let's just let him take care of you. So just saying that someone's a value member of the team.
Mm-hmm. So kind of like coming at it with some sort of affirmation.
Can I follow that? I think it's a very important point, and sometimes I think this brings up the idea that we have to upstander way with structural stuff that's happening, and so I think that this is also an opportunity for us to advocate in the infrastructure level, so that when these things happen, you are empowered to say like, it's great, I'm curious why you say that, but in this institution, we will not tolerate discrimination or something bolder as opposed to like tippy toeing because you work on Palestinian. And then for me, for instance, like I feel empowered to say that because my care told us that we can do that and we can actually fire our patients when they act like that. And we have a whole protocol that we can just call like darts, and then like a whole swarm of people want to show up and talk outside what's happening, confront the patient, and then like escort them out if they don't have an emergency, or you save them if they have an emergency, so you can actually do the best that you do. So I'm just saying that I think this is also an opportunity to upstand beyond just the situation, but also like as an infrastructure.
I want to hear more about that program.
Oh, well,
Does anyone else want to share? Not on. We're gonna go ahead and play a video. And so in this video, you're going to be seeing a scenario that occurs in an emergency department. Dr. Desai and I are going to be playing attendings. She's the teaching attending. I'm an attending that's working on my own. And Dr. Guerra is going to be one of our administrators and in triage, the triage attending.
Just try to pay attention to just the different perspectives of each person in this video, so that you can, I didn't realize I was going to restart it all over again. But just think about what the microaggressions are and where the source of recipient bystander are coming from.
Hey, Smruti.
Yeah.
Are you teaching today?
Mm-hmm.
I guess I got called from security. They're outside in the waiting room. There's some patient who maybe was just discharged. He's created like a big fuss saying something about how he wasn't treated right. He's in a lot of pain. What's going on?
Yeah, it's that guy with the knee pain. And he's been here a lot. Like if you look on the chart, he's been here pretty much every day these last 2 weeks for knee pain, and he's been seen over like the course of a year. But he was demanding an MRI. He's had this like whole workup done with CAT scans and joint taps, and ortho's seen him multiple times, and he doesn't show up to clinic. And but he wants the MRI today all of a sudden, and now he's like, I told him that he doesn't need it emergently. Given that he's walking on it, his knee's not hot, it's not swollen, it's not tender, his vitals are fine. He got really belligerent when I refused, and then got really disrespectful. He got physically threatening at one point, and was cursing at me, just saying a bunch of all sorts of nonsense. But I medically screened him as a result, and you know, looking at his chart and looking at him and his knee, I felt it was reasonable to discharge him. So.
You know, sometimes with patients like this who are really upset, it's better not to take it like too personally or react emotionally to their behavior. Maybe we should just re-triage him.
I mean, from my perspective, I medically cleared him. I feel like there's really no reason for him to be here today.
Right. You know, there's all this pressure on us to improve our patient satisfaction and our Prasgini scores. How about if I just grab one of the male residents and I'll see the patient together with him?
I mean, I don't necessarily want to expose my residents to him, but...
Don't worry about it. It'll be fine. Is this his chart? We can let's just cancel the discharge, and I'll go grab Jack and we'll take care of it. Don't worry about it. Okay. All right.
Thank you. That was my theater minor at work. Okay, so what are your initial thoughts after seeing that video? What are some of the things that stood out in the scenario? Nothing.
I think he assumed because you're a female, you reacted emotionally and not based on your medical training and accurate assessment of the patient.
Absolutely. And he decided to say it in that moment, right? To call her just like her, essentially because of the patient.
Yeah.
I gotta say, he's gonna get a male resident to see.
Oh my God. No. Because you're too emotional.
Any others?
I think the first thing, I think there was a lot of like subtle things there, but the first thing was also just that he went into your workstation and canceled the discharge order, which I assume is open in your name and you're the attending. Like that's, you're both attending. If he wants to cancel the discharge, that's gotta be under his name, not yours.
Right. So like the physical,
The physical, but just maybe audacity is the wrong word, but like the thought that you could just come into somebody's workstation and make that decision for them in their name, it's their license and it's their medical plan, and that you think that that's fine, especially in the context of clearly you're reacting emotionally and that your decision making isn't to be trusted.
If we think about one of verbal microaggressions or even audio versions of the difference, and that's the case of standing kind of like towering over her and telling her what to do, also makes a little bit, it kind of creates this hierarchy, this dynamic between the two of them already. Any other behaviors, any other words that you can say?
I have an observation, actually, after but it's striking to me actually noticing that the triage physician has like no clue that any like how this is impacting the original doc. Like just like there's like a clear disconnect there. It doesn't seem like it's kind of like a mission for this person. But it just seems like completely like it doesn't even realize.
So believe it or not, this is based on real scenario or real scenarios, and we use this video in teaching all of our attendings and many of our residents. And when we played the video, some of our attendings did not feel like there was any issue. They did not see that there was anything that was wrong. And like, you know, like we were talking about before, a lot of it has to do with our own implicit biases and how, we were brought up, the culture that we're surrounded by, the people that we're surrounding ourselves with. But like you said, like some people watch this and they don't actually see any of these things that are brought up.
I also want to just, that's a very good point, and I really love that because I think that highlights that implicit bias that you were just mentioning. I also want to give kudos to the colleague on the left of the screen because even that facial expression, right, like that is validating because I can see myself as a junior faculty just starting in this new emergency department, doing what I thought, like having great training, and then some person just like takes over the care of what I thought was like the appropriate care. Like, so kudos to that person.
It's also, I think, like, outside of the screen is like there's like chaos happening, obviously outside the hospital, but someone had to go and find the male attending and tell them why didn't they go to the triage attending or the attending that saw them, and it could be, maybe unintentional, but maybe they were looking for a male, attending to address that. But instead of going to the source, right, we discharge the patient, so when I come to me and ask me, why did I discharge them? But they kind of bypass the whole attending who's in charge to go get someone with a common sense, like to take care of the patient. So even like with our teams, right, we had perpetuate this problem as well too of like saying like, who's confident to take care of this patient when someone's escalating and things like that. So it can be challenging instead of going to the source and seeking additional information. Sorry, getting our nurses and techs as well too. I suppose like I'm actually in charge. I'm happy to answer your questions. I'm happy to go talk to the family if I need to, right? It's just, but they may not want to intrude or they may have their own reasons of why we shouldn't go talk to some other attending that is involved in the patient care. I should always try.
So I think you all mentioned a handful of microaggressions in the video, some of them being, the perception that females are seen as emotional, even though she wasn't really displaying a lot of emotion in the video. She was just speaking logically about the patient's case. Another one being the physical nature of taking over the computer. And I think you mentioned also that the idea that he was going to bring a male resident. And we talked about like what might be his intentions if we were being curious, what he might say if we asked for his intentions. And some things that have come up are maybe Press-Ganey scores. He's an administrator. He wants the patients to be happy. Maybe he feels like Dr. Desai was threatened physically because she said the patient became physically violent, so he was going to take somebody that he perceived to be stronger, like a male resident, to see the patient. And so when we do our response session, you can sort of have some of those things in mind, and we're going to be role-playing. And so I think that it's really important to take like a curious approach to this, and like you said before, like invite in rather than exclude in the response. And so we're going to go over some strategies that we can all use for a bystander response. So if you're playing my part in this, what I could have said.
Yeah. So we're going to kind of revisit kind of what we had mentioned. We planted a seed, so now we grow that seed together on the lift method, which I think actually is really effective because it has a lot of different options, even in this mnemonic itself, that can really help you to figure out what to do. And the first one seems very simple, but it's actually really helpful, is the lights on. Because in going to a lot of these sessions, and actually we have institutional-wide sessions for this as well, it's really interesting how many small groups I've been in that people were just like, I never even heard the word microaggression. I'm just like, okay, friend, lights on. It is here, right? It has been here, it's always been here. And so, yeah, and it's sad in 2023 that there's still a group of our population that still does not know that about microaggressions, macroaggressions, overt racism that is happening and taking our patients' lives and our colleagues' lives as well too. And so there's two options that we have, is to get angry or to educate. And so after getting angry for a long time, I'm now in the medical education role of wanting to educate them, right? And seeing where are they at and helping them to now take them by the hand and invite them into the space of, hey, this is a real problem, and I'm inviting you now to be part of the solution with us. So lights on, there's a couple different ways that you can see it. One is just the idea of like making the invisible visible. So just saying, things like, hey, did you notice this happen? Or do you notice that they, in the room, called you, like for my residents, I'm always the resident, and my residents are always the attending. Right? I'm the smallest one in the room. So this is why, even with my white coat, that sometimes helps, sometimes doesn't help. And so just addressing in the room how we're, some of the things that we see there. The second is actually the impact versus intent. I think that's really important. This can happen in the room itself, or you can even do it outside the room. But really, our patients or our colleagues or ourselves, we may not actually mean what the words we're saying, but really understanding the other person's perspective and the impact it has on them is really, really important. And we gave you some of those examples. Where are you from? Or, you speak really great English. It's really interesting. Even in our slows, I would say it's really curious to read these slows. The words like this student's very articulate. It's used for more people of color versus not, right? And so this is very interesting how we can, when we're actually trying to say, like, they're very, they give a great history and physical examination and have a very thoughtful and concise differential diagnosis. That's what we're trying to say. But instead we say they're articulate, and that comes off very differently about maybe they're not part of our group, right, or American or speak English, right? There's a lot of these other connotations that it has. Full stop is actually just really helpful, and I think people know this, right? If you say time out, hey, let's stop for a moment. Those are some of the things that can really help to have everyone pause, which in emergency medicine, we're not used to pausing. I live life on fast forward, and I have to tell myself to pause as well, too. So definitely when this happens, you can just say, hey, time out. There's also one that says, like, ouch. Which even that, or if we saw the facial expressions, right? Even those like nonverbal things can actually convey to the room, like, that's not okay, what's happening. And the last is actually teaching. And there's a couple of different ways to do this. I actually do this a lot in triage because I get to work with different colleagues and across different professions, as well as just, we hear a lot of this actually because, triage, we all know, is the shift that tries to break our spirit. So while we're out there and our teams are also getting pummeled as well too. This is where some of these slips kind of happen, or some of these like unintentional microaggressions come up. And so it's really important, especially I hear a lot of this is surrounding weight, especially, and that's the population that I think we don't think about, and jokes being made and all of these things. And I always say, I used to hear that or think about that too, but we know that patients who are overweight get poorer care, have poorer outcomes as well, and they also have this shame with them. And I always share a story of like a 30-year-old male who came in who was in extremis with shortness of breath. And the whole time, even though he couldn't breathe, he kept saying, I'm sorry. He's sorry that we needed extra people to lift him into the stretcher, that, that he was sick and all of these things. I still remember, I was like, he was dying. And he was telling us, the healthcare system, that he's sorry. And I just remember in that situation being like, I am sorry that we've made you feel this way, that you waited so long to come to us because we've shamed you, right? And so it really does impact our patients and whether they feel comfortable coming to us or not. So there's a lot of different techniques, and you'll see like in different situations, different ones work or not, but just having kind of this in your toolbox can really make a big difference.
We're also going to pass around these microaggression response toolkits. So this has a number of different response styles, and it's not really prescriptive. You can kind of take a look and see if any of them speak to your style. And we're going to be taking the next 20 minutes or so to practice in small groups how we might respond in this scenario if you were the bystander.
Hey guys, we're going to kind of gather back together again, if that sounds good. So we're going to watch a second scenario now, and just again, kind of like pay attention to those like verbal and nonverbal kind of cues that might be happening here. Then we'll kind of get back to your groups and get to practice a little bit more on putting these words into action, because I think we can all agree this is hard. Right, even like we're helping to run the sessions and stuff, but still there's so much learning to be done. And so we'll watch this video and then we'll kind of get back into our small groups.
Hey, Dr. Arno. So this guy I wanted to present to you, I feel like this slug's a little cooler. I tried to Doppler, I couldn't I couldn't appreciate a pulse, and even when I'm palpating, so I can't find a pulse. I don't know.
All right. I agree. I don't feel anything palpable, and if you're saying that there's nothing operable, then we should probably call vascular concern for ischemic blood. Okay.
Yeah. Okay. I'll call him right now. Hey, operator. Can I vascular to the ED, please? Okay. Thanks. All right.
Great.
I'm the vascular fellow.
Hey, so the 70-year-old guy, we're concerned for ischemic limb on the left side, has no operable pulse, no palpable pulse. History of PAD, I think, has not been interviewed on before. I'm not entirely sure. We started him on some heparin. CTA is pending. Pre-op labs have been drawn. Pain's been going on for about like the last 12 hours.
Okay, so what else is pending?
We just.
I think we're just gonna take him up to the OR. We actually know this guy. He's a frequent visitor in the clinic. If you don't mind, can you just make sure that we have a type-in screen sent up, and I think the nurses up in the OR should be ready for reports. Like they're pretty good.
Yeah, I'll have to ask one of the nurses to do that. I'm good at attending.
Oh, sorry.
That expression is perfect. So, for this role play scenario, we want you to think about what it's like to be the source of a microaggression.
Can I just give him a lot of props here? I feel like, especially at this table, I beated the crap out of him for like being the role. So thank you. I really.
It's real allyship, letting us make him begin to make all of our videos.
Do you want to go over the assist framework?
So, arguably one of the things that keeps coming up, right, is how do we get past this the defensiveness that a source has, because we all have the ability to be a source of a microaggression, right? We think about, it's really easy to think about all the times when we've received them. Maybe even a little bit easier to think about when you've been a bystander and didn't really know what to say, but it's very hard to kind of look inside and think about what you would do or say when you're a source of a microaggression. We're not alone in thinking that, and so there's this framework that's been created. If you're thinking about training your residents, your fellows, your ancillary staff, I think this is kind of a good framework to give them for how exactly do you apologize, right? Because you also don't want to overdo it in a way that now the person who you're apologizing to has to make you feel better. You don't want that. No, it wasn't that bad, when maybe it really was that bad. So how do we own the fact that we made a mistake, thank them for feedback, right? So it always starts with acknowledging that you made a mistake, acknowledging that there was some bias. When we were doing this role play in the previous scenario, did anyone play the source? Was it who was it at this table? Did you? Did you apologize when they called out the microaggression to you?
Yeah, I think I was playing beach, so really happy that. So less apology and more confusion, more than anything. I think that was the takeaway that we were going for, like trying to. The microaggressor, the source isn't often aware of what they did, and especially if you're dealing with it after the fact, I feel like it's harder to recall the exact events that happened. And so talking about as a bystander, bringing up and kind of seeing the microaggressions that makes the source a little bit more aware. But I did end up apologizing kind of realizing it was my actions.
Yeah. So I think kind of if you find yourself being the source for a second, first just kind of separate yourself from the situation in a way that, like, all right, this is not a personal attack on me. This is a person who's trying to teach me something. And so focusing a little bit, separating yourself from your own intentions and focusing on the impact that you had on this person, right? Like, didn't realize that it had this impact on you, and thank you for bringing it to my attention. Acknowledging your bias may be difficult in the moment, especially if you don't realize it, but even just saying that maybe there is some implicit bias that I didn't recognize, and I'm going to reflect on this. Making that commitment can be helpful. I think seeking feedback would be my favorite place to start. Thank you for bringing that to my attention. Can you tell me a little bit more about that? Because I want to make sure that I learn from this. I think just showing this authentic commitment to learning is the easiest place to get yourself on equal footing with the other person and make it more collaborative. Anyone who has used this framework in the past or has been in an encounter with someone who did use this framework and provided good role modeling?
I have not seen this done, but I would share that the first scenario when we were role playing it, I was really feeling unsettled, and there's a lot more emotions that I thought at first could probably call out. In the end, as I was reflecting, I think it was because of, despite the role playing that we were doing, there was no acknowledgement that, well, I'm sorry, or it's just something to just acknowledge the other person, even from the bystander or the source, that maybe just whatever responses that we were giving, I was like, why do we have to do that? Like a lot of these things, right? But I think it was just that was missing for me, that I wanted to at least hear that the other person was being acknowledged for what they just experienced. So this is super helpful.
Absolutely. And to bring home your point, because sometimes if you're the bystander, you're not always going to be addressing the situation in real time. I personally like to address it afterwards, but yeah, if you're doing it in person, if you're doing it in real time with the consent of the recipient, then it is important to acknowledge the recipient's side of things as well. So I think especially if you find yourself in the source, you have to focus on, the focus is on them, right? It shouldn't be about you and your feelings, it should be about them and their impact. So we're gonna go back into our groups and role play the end of this scenario. This time, I want you all to practice being the source. To put yourself in the source's position and see if this framework works for you or if there's something else that works for you. It may bring up some triggering emotions, and if that's the case, if you feel uncomfortable, feel free to step out. But this is a safe space. This is a place for all of us to make mistakes and learn from them. So I hope you all get something out of it.
We're asking how would you like to be, which sometimes it takes a long time, yeah.
All right, excellent.
All right, so as we're wrapping up our small groups, I want everybody to go to the QR code, and if everybody could just write in some of the lessons that you learned from the small groups, maybe one or two of your takeaways into the shared Google Doc, and then we can kind of talk about some of the lessons from the small groups.
Yeah, it is, yeah. It's fun to see all the anonymous animals on here. Yeah. We have a ferret, we have a beaver. A goose and frogs. Yeah.
Someone's in I figured. Thank you.
Yeah. No, I got something to do.
No, it's a demon.
Oh, wow.
Yeah.
That's intense.
Intense.
I'll start with the first one if you want to start. Yeah.
All right, so feel free to keep typing if you're in the middle of typing something, but I'm just gonna read out some of the lessons that were taken away from the small groups, because I know not everybody's small group was the same, and maybe we can all learn from the experiences that we've all had. So the first one is keep apologies simple and briefly say how you are going to do better. And in our small group, we talked a little bit about how you can't take back what was said. If you are the source, you can't just, take back those 5 minutes of both of your lives, but you can say how you're going to change, how you're going to do better, how you might be learning, and sort of how you're planning to improve so that type of thing doesn't happen again or happens less frequently. The second one is, this is hard. This is really hard. Thank you all for being vulnerable in these groups and being brave. It is definitely hard. Discussing your feelings makes you vulnerable and might be appropriate in certain settings or relationships and not for others. So this is something that came up in our group as well. Essentially, you might say that made me uncomfortable, but we also talked about how that sharing of your feelings and sharing of your emotions puts you in a vulnerable position and might not be appropriate depending on the relationship that you have with the source if you're speaking to the source. And so we can kind of generalize and say, in situations when X happens, it is thought, or we can say something like, well, that was uncomfortable, rather than sharing it as one of our, something from us. Somebody wrote action statements to follow up. It's okay not to get it right the first time. Be open and receptive to feedback. Use I statements to disarm. Set an example for those around you. If you mess up in public, apologize in public. And it's important to be genuinely curious when talking to a source. Otherwise, the conversation could be ineffective. And we saw some examples of this as well, where we saw what it looked like from a curious perspective, and that sort of partnership with the source, from the bystander addressing the source with some curiosity. And actually, when the bystander addressed the source with some curiosity, there was an acknowledgement of the intent from the source, and that kind of can lead you to some sort of shared mental model and sharing what the impact was, while also understanding the intent and coming to some sort of shared conclusion about how this impacted the recipient.
On that same document, if you want, right below is like challenges. So if you wanted to kind of add that on, but I think we could all acknowledge this is challenging. Probably that statement in itself is probably enough. But some of the comments we have so far. So I wrote the first one. I'll admit it's like finding your voice is really hard in these situations, right? They could be very intense, or if you're focused on the patient care, you may not actually even acknowledge that it's happening, right? Which is important. But our learners, the staff in the room, they may see it happening, right? So that's why it's important to at least be able to be aware and always looking for these situations that are happening, unfortunately, especially in the ED, but in the world itself on a daily basis. The second is navigating the pre-existing relationships. That is very much a challenge, because as you speak up, you can imagine calling people out versus calling them in can really change that power dynamics. And unfortunately, unless you want to keep switching hospital to hospital because we're burning bridges, we have to be thinking about how do we make this collaborative and communicate with these teams to really maintain that pre-existing relationship, but also call all of us to grow together in this space. The third is does it matter to say it wasn't your intent? That is a challenge. Intent versus impact is always a challenge to kind of navigate between. And I think we were using the general they, they won't let me prescribe medications, right? So that same they who is doing that, you can use that in the situation to just say, when this happens or when this is said, this is how it can be perceived, and just calling people into that other perspective, I think, is really a healthy way to grow together. Trying to find the balance, balancing the line between I'm sorry you felt that way, and also focusing on impact and make it sound like it's a real apology. And I think a lot of times in doing like crucial conversations in some of those other classes as well, as soon as we use the word you, it's not productive, right? I'm sorry that was you. It makes it a you problem instead of a us problem as well too. So instead, for relationships in general, they actually encourage using I statements instead as a healthy place, because the word you puts people on edge as well too. So that's one way, but that is a challenge kind of. And also if you find yourself saying like, I'm sorry you felt that way, then it's just like, oh, how do you backtrack to fix that? And it gets very, very, very hard. And then try not to over-explain yourself, which may lead to more harm. I think that's right. We tend to, in medicine, rationalize, compartmentalize, and all of these things. So it gets really hard to not try to justify why we said something in that moment, because unfortunately, that impact is still there on that person. And so when we find ourselves being the source, or other people, whether it's our staff or our patients being the source, we may see this over-explanation. And sometimes it's okay to just like help them to stop the over-explanation, just saying the impact of the words that were spoken. And then also how to move forward together, because we don't want to shame each other, but we do want to make it a productive relationship. And then kind of like finding your safe people and allies to bring these conversations and trainings to your institution. I think that's really where we want to empower all of you to feel like advocates and allies to be able to do this, even if it's not running like a scenario or workshop like this, even in the clinical environment, just even on shift, saying this and talking about this to your residents and your nurses and stuff, it really actually is a very fruitful conversation, because they're seeing it day in and day out, especially when they're interacting with different specialties and each other as well. This is part of, unfortunately, our daily life. And so it's really important to know that you don't have to do a workshop. You can just bring this into your normal conversations in the ED itself, and even that in itself will transform the way we do medical education.
Just in terms of facilitators, any pearls of wisdom, anything that came out of your conversations that was very fruitful? Let's start with this table.
I think we had a couple of questions on there. I think this is also open to groups, so please feel free to. Does it matter about, as a source, does it matter talking about your intent? Because I think when we were role playing, some of it was you're trying to give reasons why you made use of some bias or talking to Teresa, and she was saying, oh, you were wearing plain clothes, so I assumed you were a doctor, or that's why my thought process went there. I think we were talking about intent versus impact, and does it matter if you say I didn't intend to clarify that you're not actually sexist, racist, biased in a certain way, or does it matter? Does it matter at all?
So I think it depends on the conversation that you have with your bystander and your recipient, right? Because sometimes someone like me will probably ask, I was just wondering what you were thinking about. What was your thought process behind this? And if they ask you, you should explain yourself, right? I was coming from this place, but then you should also not discount the bias that probably went into it. I think a good framework is saying, well, thank you for asking. This is what I was thinking, but I also realize that it also comes off as if I have this bias. And I'm going to reflect on that some more. I think that's a framework that works very well, because you're not making excuses for anyone. You're explaining yourself, but you're also not discounting at all that what you said could have come from a place of bias.
I like the framing that if I was the source, it's not on me to make that explanation, right? Like, I'm not asking you for that. Like, why did you think I was a nurse? Because if you don't ask me that, then sorry is just period, full stop. I don't need to explain, right? Because the more I explain, then I have to ask myself, why am I explaining? Is it for the other person that I just offended, or is it for me to feel good about myself? But I apologize. If it's the latter, then I just discounted all the apologies that I just did.
Yeah, and that is the hard part, is like sometimes with the explanation, it could be seen as a justification instead. And so sometimes just the power of acknowledging that someone was hurt, and that we you didn't intend to hurt them, but that was the impact of what we said, and just saying, I'm sorry, very genuinely. And I also find that saying what you're going to do differently in the future is really impactful for that person, just to be like, I'm going to be more aware of, what I'm saying or how I'm acknowledging, or at least from the future, I'm going to see, like, have everyone in the room introduce themselves so I know everyone's role so that we can work together, right? Some of those simple things will actually help them feel more empowered as they leave the room, because they help you grow as a person.
I think that just a simple, I'm sorry, that's my bad, and that was not cool, goes a long way. I don't think you need to explain yourself, especially if they throw you off, right? If they're like, well, why did you think I was a nurse? And you immediately are like, I don't know. Don't try to explain it. Because you know it came from a place of bias, just apologize. And I also, following it up with...
That came from a place of bias.
Yeah, you could also just say, that came from a place of implicit bias that I need to learn from and I need to think about. And thank you for bringing it to my attention. One of our learners did this great thing where she was like, oh, my bad, I'm so sorry. I will not assume that in the future. Do you mind pointing me towards a nurse who I can talk to give handoff? As opposed to being like, oh, can you go talk to the nurse? She sort of made that equal footing where she was like, all right, well, you know what, I will go talk to the nurse, and I'm so sorry that I made this assumption. Another thing that came up in our group was, part of the ASSIST framework is talking about acknowledging your bias. And that can be very awkward in the ED, right? If you make an assumption and it's in a sick patient and you're like, oh, I'm so sorry, I made this assumption that this person was your mother or your sister and not your partner. Something like that. I think if you're authentic enough about your feelings and you say, I'm sorry, I made this assumption, I will do better, you don't need to stand there and be like, I made this assumption, I have this implicit bias against LGBTQ patients that I need to go think about. You don't need to go over-explain that. Acknowledging your bias on your own and making this commitment to change is good enough. And if you make that commitment internally, your apology is going to be authentic. Because the whole point of this apology is not a blaming tool, right? You're trying to learn from it, and so just kind of manifest that in your apology. That way, I'm going to be better. I apologize.
It also creates space for the other person to, because maybe they're angry and they're allowed to be angry. And I don't need to file that right now. Like, I just need to extract myself from that because I caused that. So I apologize, and maybe later on I can touch back and say, I'm so sorry again, or whatever. In the moment, I think there's a natural reaction also, because we're well-meaning people, we don't want to let these people out. So you try to make them feel better, and in the end, I can see myself actually making it worse for them.
Absolutely. I think the ED is such a great place for us to be growing all the time, right? Because it's easy to make mistakes, and there's a lot of lessons that I've learned just from taking care of patients that I feel like I can use for microaggressions. When we make a mistake with a patient, right, or a patient is upset because they're grieving and there's something about your care that they don't like, we always take the passive, I'm sorry, let's start over, right? And I try to, if I ever find myself as a source of a microaggression, I try to put myself in that same position of it's my responsibility to start over. It's my responsibility to equalize this a little bit. So I think kind of resetting your framework to that, because even when we're physicians, we're always thinking about learning, and we should have that same attitude these encounters. Anything else that came up as a facilitator? Any wisdom?
I think we want to definitely give you guys a break, though. It's the other part. So what we thought we might do is have you in that QR code that you guys all have access. If you have any questions, we can always address that also at the very end, if that sounds good. And luckily, we're a small group, so this is fun that we can make this more collaborative as well, too. We definitely want to do a quick shout out to our wonderful actors and actresses for our session.
Yeah, Dr. Aguirre was my simulation fellowship director, and he was a big part of developing this the whole debrief rubric, and he's happily been working with me for a lot of sessions. So big shout out to him, and to Dr. Arna, who took time out of her busy schedule to come at 8 in the morning and shoot this video. And Dr. Lamberta, who is also one of our colleagues, has been very, very present and active. So I just want to acknowledge their assistance with all of this. Thank you.
Awesome. So we'll give you guys maybe a 10-ish minute break, if that sounds good. We'll try to come back at 10:35. And then after that, we can kind of let our next speakers take the floor. Thanks so much.
Okay, are we still alive? Are we still awake? Even though we all didn't get all of our coffee, it's okay. So my name is Teresa Smith, as I said initially. I am the Associate Dean of GME and the DIO at SUNY Downstate in Brooklyn. And the pleasure of training two phenomenal doctors who set up this panel and workshop today. And I'm still working as a practicing emergency physician, and my partner in crime.
Hi, I'm Melanie Cheng. I'm actually a pediatrician clinically, but I am the Associate Chief Academic Officer at Kings County, and I've worked a lot with Dr. Smith and also both of you two to do a lot of this similar work, so we're excited to be here. So what we're going to go into a little bit more right now is going beyond just diversity into inclusion and belonging, and then we're going to try to put together some tools for everyone to take with them. So neither of us have any disclosures. So the learning objectives for this part of our talk right now is that we want to talk more about defining a specific culture of inclusion with some examples of environments that are inclusive versus isolating, and discussing why inclusivity matters, and then the steps that we can take to actually be able to bring that to our institutions. So the main thing that we just wanted to touch on here is the difference between diversity versus inclusion. And I know Dr. Bryant mentioned it a little bit earlier when she mentioned diversity is being invited to the party and inclusiveness is being asked to dance. And so some of the main issues are not just whether you're hired or recruited or are part of a department or a program, but whether you are included in decision-making, in policies and procedures, whether your opinion is valued, whether your perspective is actually taken into consideration versus just being part of the staff. And what we want to really look at is what are some of the factors that contribute this on a larger system for policy in terms of how we write our policies, but also institutions, systems, programs. So I know we discussed a little bit earlier and the question came up about how do we roll this out, or how do we get people to buy in, or how do we put these workshops together so more people can hear, and that's what we want to work on with you all today. And then, so this is just kind of going over some of the differences in terms of diversity, inclusion, equity, and belonging. And really, there is obviously so much overlap, but what we want to get to with all of these aspects is really belonging. Because when there is a sense of belonging, that empowers people to be able to thrive in their environment as a learner, as a physician, as an educator. And so that's really what we're trying to get to.
So we also just want to talk about some examples where, some of our learners who are disenfranchised or underrepresented feel like they don't belong, and where these situations really can impact their performance. So thinking about social isolation and, thinking about, okay, if you are recruiting these learners, right, everyone's trying to do diversity recruitment, but is your environment one that's comfortable and accepting, particularly if they're the first ones, right? So many of our institutions, many of our departments, they're gonna have the one and only. Somebody has to be the first. And so here is a perfect example of a study where they're looking at underrepresented in medicine residents and feeling, talking about their feelings of isolation. And I just want to read this quote. You'll find those individuals talking about things that you're not accustomed to and you don't find yourself being a part of, like golf or wines, things that I myself have not been exposed to in my sort of social experience. So I don't have the same bond or kinship that they have. And this lack of these shared experiences that your counterparts may have, even if they're being friendly and opening and wanting to, accept you into their environment, it can cause a bit of frustration and conflicts within the individual themselves. Also, this study, there was an open-ended interviews with about 19 Black residents in a U.S. medical training program. And they found that 13 of the residents described having unfair punishment when it came to very minor transgressions. So they felt like they were punished more harshly than their counterparts. They had fewer chances to make mistakes. And then now they're setting up themselves psychologically, like I cannot perform without an error, because when I do perform with an error, I have higher stakes than my counterparts. And again, we've been saying this, all morning about that feeling of, okay, great, we're all recruiting for diversity, we're asking you to come to the party, but we're actually asking you to dance. Are we actually setting up our environments that everyone feels like they belong there? And again, thinking about stereotype threat, which I encountered a lot as a program director and even more as a DIO, where residents who you get that first insult and then you can't let it go, right? That happens to all of us, right? Somebody insults you and that's all you think about is that insult, how you reacted, how they reacted, why did they say that? Why are they isolating me? Do they not like me? Am I not performing well? And this is called a stereotype threat. So Dr. Claude Steele, who was the dean of Stanford Graduate School of Education, first coined this term of stereotype threat. And he gives this example of women in mathematics. And so during his research and his study, he looked at the amount of women in undergraduate courses for mathematics. And he said, imagine you're a high school student, you do really, really well in math. One of your professors or your teacher says, you should really go into mathematics, and you decide to go as your major. And then you get into college and you see that there are only a handful of women in the mathematics major. But you're persistent, your high school teacher told you that you were good at math. But then as you advance in your courses, you see less and less and less and less women. And then eventually you start to question yourself, do I belong here? Do people think I'm not smart enough? Now I'm the only one and I'm representing my entire gender because I've been told that women are not good at mathematics. And basically what they found was that women end up dropping out of mathematics because they felt like the environment wasn't conducive for them to learn. And you can see this in many, many other circumstances. Even so, he did another psychological behavioral research project where he would have the participants come in who were women, and he would say to them, women aren't usually good at math, but on this test, they actually ace it. They actually do really, really well. And what happened was the women ended up outscoring the men on the test. Just by giving that positive affirmation that women do well, they ended up feeling like they could succeed. Very, very strong evidence as to what he ended up coining as a stereotype threat. And that's basically the fear of fulfilling this negative stereotype about one's group, which impairs your performance. And so we can see this in actuality in medical education, and this was a study looking at clerkship students. And basically, again, what happens is you can imagine the person in the middle, you're having that internal dialogue. Did that person just say something that was racist or sexist towards me? You spend so much time in your response mode that you're not actually doing your assessments or whatever you're supposed to be doing for your course or in your clerkship. You're focusing on the incident that happened, and it takes a lot of cognitive load. And then what ends up happening is that the underrepresented or the female performs worse, right? Because their counterparts are not perseverating over whatever just happened. And so here, one part of this diagram that I really liked is the allies, where the allies can interrupt this cycle that unfortunately individuals go through. And these are the different types of responses that if you are experiencing a stereotype threat that you may go through. Avoidance, right? You might say, you feel paralyzed to speak on it and simply I just don't want to deal with this today. Denial, maybe that really didn't happen, just starting to rationalize the perpetrator's behavior. I'm sure they really like me, but you're still going through that in your head. Prevention, and you feel like, okay, well, maybe it was me. Maybe I need to fit into the dominant culture and make sure that I really pronounce my words so that I sound more Americanized. Deferral, you can say that I'm just going to respond to this later, or I'm going to talk to my therapist about it later, or go to the diversity officer and talk about them later. Often, though, what I see probably more than any is confrontation. Now you're upset, right? Because this person has offended you, and you want to directly challenge the threat. And oftentimes, these individuals end up getting labeled as disruptors, or the person with the conflict, or they get sent to the DIO's office. And it's really because they had one incident that actually did happen to them that ends up becoming exacerbated in their head and may not, whether the perpetrator meant it with intent or not. But now you yourself are going through this cycle.
So why does this matter in the context of medical education, patient care, clinical outcomes? If we look at sort of the numbers and what we've been doing in terms of recruiting, the numbers, especially when it comes to gender, have equalized over the last decade. But if you look at how that translates into leadership position and retained faculty, it's not translating at all, which I think we'll go into a little bit more later. And that is in part because we may be trying to increase diversity, but we're not putting the same focus on inclusion and belonging, and how we're supporting, all of our different members that are on our team. And each of those people will bring in different perspectives. And that will correlate also to patient care and patient outcomes. Because there's a lot of things within all these different perspectives that if we're listening to and we're giving a voice to, can translate into how we're showing up for our patients, how we're treating our patients, the things that we may not even be addressing that are contributing to poor outcomes in some of our patient populations more than others. So it's whether it's for the learning environment, whether it's for our role as educators, or whether it's for our role as physicians and in terms of patient care, this is something that we do really need to focus on, because all the work we're doing in recruitment is not going to be as effective if we're not working on retention as well.
And so Dr. Barbara Ross Lee, who was the first African-American female dean in a U.S. medical school, at the last ACGME conference, she was asked the same question, why does diversity and inclusion in medicine important? And her response was that diversity, equity, inclusion is the means to an end, which is equitable care for our diverse, underserved patient populations. So, when your chairs and your CMOs ask you why we do this work, it's because you want health equity, right? So we need to get at the root of how we can get to health equity. And Kimberly Crenshaw, who coined the term intersectionality, says, if you don't have a lens that's been trained to look at how various forms of discrimination come together, you're unlikely to develop a set of policies that will be as inclusive as they need to be. So really, to understand and to really create equitable environments and be inclusive, then we need to, again, get at the root of the problem. And I love this diagram because it shows you what we're all doing, right? We've been tasked to do, we've been demanded to do by the ACGME, by the LCME, that we need to have a diverse workforce. So we're all working to build these pathway programs, right? But how do we stop, and we shouldn't call it leak anymore, we shouldn't use the word pipelines, we should say pathways for our Indigenous colleagues. But just keeping that framework, we have a lot of individuals coming in, but how do we retain them, right? And we think about it like equality imagines that there's imagines an equal world, right? We all care about one another. But if we had equality, we have to consider the fact that there are people who get stepping stones just naturally. They've been born into families that have higher economics. They've been born into a neighborhood where there are great school systems. They don't have to worry about food insecurity or housing insecurity. So it's not actually equal. There are people who have more advantage and more privilege than others. And then thinking about, okay, well, if we get more people into this system, we first must acknowledge that the system is cracked, right? Not everyone's ladder is built just straightforward. And again, some people have stepping stones and more privilege than others. And what we're doing is this right-hand picture, which is basically we're saying we need to get more people into the pathways. Within the same picture of diversity lens focuses only on bringing more students into unequal pathways. What we really should be doing is not only bringing in more students, but again, this is what we're kind of talking about, we need to create systems where we have a set of belonging, where people can actually thrive, right? Not just bringing people in, but where you're going to be fixing these broken ladders to allow people to have the same equitable chances to succeed as all of us do, even those with privilege. So again, just bringing up some evidence, and we'll just go through this, very quickly, basically shows that those who were identified as female, non-white, or LGBTQ felt more marginalized and had more discrimination than their counterparts, and quite frankly, felt more exhausted. Also, this is the work that Melanie and I are doing and going into, is to look at how often these minoritized residents are terminated or forced out from programs. And it's shocking to see that this was a study done, or data, I should say. It wasn't even a study because it's been very difficult to capture this data. But Dr. Bill McDade of the ACGME is probably the only person who actually has at least some of the data to show, and this is from 2015, 5% of all the residents at that year were Black. Yet they made up 20% of those residents who were dismissed. right? There's not a lot of residents who are dismissed each year from residency program, but for it to be 20% to be coming from, you know, the Black ethnicity or diaspora says a lot. And that really does speak to the fact that, okay, we're getting all these diverse workforce, but what are we doing to create inclusive and comfortable and safe working environments for all, not just for our minoritized residents, but for all. So we're gonna spend the next few minutes trying to create system changes. So everyone has a poster board at your table with a worksheet that has some questions on there. And we can see the questions. Can somebody read out the questions? There are 2 sets of questions that we want you to work on in your small groups for the next 10 minutes or so.
Identify strategies to minimize frequency of microaggressions in the institution, and/or discuss best practice in teaching faculty, as for instance, students handling microaggressions in the workplace.
Great. So we talked this morning or earlier this morning about your individual perspective and what you can do as an individual, and now we want to know systems issues and what the system can do. So you have Post-its and a marker. You guys can start to jot down. If you can come up with at least 3, if you want more, that's fine, but not too many, but at least 3 ideas of either of those topics or both of those topics, and we'll give you the next 10 minutes as a group to come up with that. Yeah, it's a Post-it. It's a giant Post-it. Yeah, poster. It's a giant Post-it. It itself is a Post-it. And we're gonna have you post it on the board. Yeah. Okay. All right. So we have the second part of this. You won't have to stop your conversations for too long. There's a second part to this. So everyone has Monopoly money on their table, or printed out Monopoly money. How much is it? $1,500? It's around $1,500. So what we want you to do is, you guys are now the C-suite, and you need to put money to your ideas. We are going to have you come up with your business plan and business proposal and present it to the group. So you have your money, you can prioritize your ideas and say you're gonna put, you know, $1,000 on this idea, this is the first thing that you're gonna do within the first year. And then maybe you'll put a smaller amount on the different subset of ideas, whatever you need to do. You've got the money. We've given you a boatload of cash, you're now all rich. Come up with what the business plan is gonna be, and then we are all gonna hear what that is gonna be like. Okay, so we'll give you another 10 minutes for that. Okay, all right. Our C-suite members, we're excited. Actually, Melanie and I are probably going to take a seat. Actually, we can go up there like judges. Judging you all. Okay, so what group wants to present first? Their business proposal, their ideas and business proposal, and where you put you allocated your funds, your resource allocation. Would you guys like to go first? And then just put your board up on the wall. Everybody can put their boards up on the wall and gather around your boards. Well, that's a Post-it, not your money, but you can tell us the dollar amount. You don't have to put your monopoly. Just write down the dollar amount so you know for each idea.
It's like Shark Tank.
Shark Tank. Oh, this is fun.
Right. I guess, I mean, we've been doing something similar at Attendees, but we felt like the most useful thing was just giving everyone meaningful training about microaggressions. We particularly chose the word meaningful because the mandatory trainings typically are not like terribly small start ideas, but it's not meant for us like doing something like this, like having small groups, having some sort of
love how you prioritize, like the mass-wide departmental training is definitely gonna cost a lot more money, but it does allow you to like kind of think like, okay, yeah, you might want a little bit more money for your community out of there.
Yeah.
Awesome.
I would also add, it may actually cost educating the clerical staff and admins more than we expect. Because a lot of them are gonna want paid time or overtime in order to do that outside of their shifts versus faculty and educators and residents, we can build that into our, faculty development and things like that. But the admins and clerical are actually cost more than we think.
C-suite powers. All right, next group. Thank you.
Yeah, team. See the organization project.
My superiority. So we decided to put a lot of money towards collecting some data because it is the most boring and yet the most important. Not boring is not what I'm going to say. Most important part of changing your culture because it's to prove to whoever's being that we actually need communities training in January. So we couldn't decide between data collection and examining your own policies, which of them required, which of them was required more money. So we ended up giving $600 for both. One was to basically get pre-writing surveys on the culture of inclusion, and the other one is to examine your own policies for bias and inequality. And we figured between the two of them, we have enough information to CEO or implementing better practices in the state. We also had, we have faculty development and improving baseline knowledge and training. And there's resident education with role plays, submissions, stuff like that. And we realized, both Alay and Arlene brought pretty excellent points about the fact that residents are always leaving. And you don't train your attendings, and your culture's gonna, you just keep starting back to square one every few years. So we want to put slightly more money into training our attendings and faculty development. Put $300 there, and then another $260 for resident education, getting a conference, and incorporating all three education into our basis education. Part of our resident education was also to emphasize simulation and role play, and also create a longitudinal curriculum, incorporate some safe space sessions. So basically, it's almost the same amount of money, but we want to put a little bit more towards attending. Because the concert can stay and continue to train and and then we put $2 towards funding towards getting other outside experts to help. They're not always the most useful. You also need a lot of data to get their advice for treatment. We figured between attending education and resident education, us running our data, it was sort of the lowest part of us. And again,
It's the pay for the GoFundMe tax.
It's a GoFundMe tax, yeah. Yeah, I do appreciate you starting with data, because in fact, providing data will get you more funding. So that was pretty smart for me, right? You can provide the data and the hospital will fund the initiative. So I encourage people to definitely tackle that. And your data may not be that much money, so you can perhaps get more than $2 honorarium. You're one of us. Awesome. Great. Any other comments?
We were really torn about collecting data versus just focusing and implementing some change. Like focus on the policy, just like strip all of these things that are historically just biased. And I think this is the tension between like the researcher versus like I'm more of the clinical operations. Let's just change some stuff, pilot it, and see what happens. So maybe we can work together and like do some research on like what we're implementing as we're moving along, as opposed to in academia there's this sense sometimes like we need more data, and so like there's this paralysis of moving forward just because there's no data. Well, like, what in fact like we we have some data, it's just, we may not feel like it's, it applies to us.
Yeah, we're gonna give an example of where we are collaborating, so that we can have data as we go along. Because it's really, you have to get your researchers or those who like research involved early with you.
Yes.
Because it really is important to prove that what you're doing is efficacious. Otherwise, like it's just gonna go to the wayside. Plus, we all need to be publishing in this work, right? This is like the minority tax where we're doing the work but we're not getting anything back for ourselves for promotion and so on and so forth. So it's really important to carry data mongers with you as you go along and push through.
I love the duality of it, you both, so just one.
Yeah, absolutely.
Especially when you're coming up with more innovative ideas or areas that are untapped and you don't have data right now, because then that can show us where you need to be putting our money and our resources, because right now there isn't an answer for that, and we can't have an answer unless we can show. We could go straight a bunch of policies, but if we can't show that that did anything positive, and then it also means we're not measuring or taking into account the economic consequences that we may be causing some harm that we weren't really thinking.
Yeah, if you're coming from your own perspective without assessing it, then it's just like, you become the problem. Awesome. And our last C-suite group.
Should I just like jump up and do this?
This counts as a national presentation, you must do.
Check.
I am superior.
Love it.
So our ideas actually kind of fell into the hierarchy, like as we came up with them. So the first one was superior remodeling, which is actually happening at Sonia's institution a little bit, it sounds like. But in order for this to happen, we realized that we would have to have trainings, we would have to have faculty
we're going to talk to you about some of the, one very specific idea project that we are working on at our institution.
This is one of my right? So at our institution, what we've started, and what we've really taken a look at is, as we started to mention earlier, is remediation and the rates or disproportionate rates of underrepresented in medicine residents who are terminated or pushed out involuntarily or under duress and leaving the profession. And like we said, this is one way we realize there really isn't very much data on this at all, and Dr. McDade is really the only person that has any. But what we wanted to start to take a look at is what are the system and learning environment factors and faculty factors and training factors that go into what leads to those residents who end up on remediation or termination or dismissed. And so our idea was to take a root cause analysis approach and treat it like an RCA and be able to kind of look at all the factors that may be leading this person to remediation. For example, if you have a resident who is, a Black resident who is always thought to be the tech or the janitor or patient transport, and their patient is saying, my doctor's never come to see me. And then they end up being accused of not seeing their patient or lying in documentation by putting in a physical exam when they didn't actually see their patient. But the issue is not that they weren't seeing their patient, the issue is that their patient didn't recognize them as the physician no matter what they do. Is that, examples like that, are these the things that we should be addressing on our end and that they shouldn't be penalized for, and how is that affecting both who ends up on remediation, who gets terminated, and who is identified where, and then also what are we putting in those remediation plans? Because if most of the remediation is really on the faculty or learning environment or institution, then it's really us on remediation, not the resident themselves. And so we've put together a committee that is going to be taking this on, but it is a huge lift in terms of the amount of work that goes into each and every resident that needs to be remediated. So that's where kind of we wanted to tie back this idea of how much of your resources are you putting into it. You need expert faculty, you need data. We are going to need to follow metrics in terms of what's working. And we need time, and we need faculty time. And there's not a lot of money dedicated to this area in most institutions. I think you have that. Did you want to go this one?
Yeah, and we could just wrap up with some other ideas. So, just to go back. So for that consult service, which we call the grad committee, GME, remediation, assessment, and design, we are applying for grants to try to help supplement the cost of time for the faculty experts, and also to provide maybe psychometric testing for the residents and trainees who may need it, to subsidize for them. I don't know if you all know, but psychometric testing is like $4,000, and you have to get it renewed every so often. So to try to, you can imagine that that's a disparity in and of itself, right? If you can afford to do that so that you can get accommodations versus those who can't. So all of the things that might be in the environment in the root cause analysis, we're trying to see if the group would be able to help with. We would be a consultative service, so that programs would tap us if they had a trainee who needs remediation, and we would do this investigation to figure out what are the causes that are based off of inherently the trainees' deficiencies or areas of improvement, and here are some suggestions on how to remediate it versus what are the causes in the learning environment, and this is what the program needs to do to fix the issues. The other thing that we are doing is we partnered with an MPH, or one of our ED faculty, who's going to be doing research along with us in parallel. Actually, they're classmates. They're a classmate. So that we can make sure that we have publishable data to show that this project is actually, this committee is efficacious, and we can publish it and show that it's been useful and acceptable model for remediation, and hopefully change some of the ACGME standards around remediation. Some other things that you can do, and this is just another paper that we did, or I did with some other colleagues, looking at recruitment and retention, because again, we are always thinking about the recruitment aspect, but you guys came up with some of these things with retention, right? Mentorship, having a supportive clinical learning environment, creating communities, and then here's another list that again tags recruitment with retention, looking at all the things that you can think about when you think about retention, right? Promotion and tenure, right? If you're tapping your faculty, even you all who are the Jedis, need to make sure that you're getting credit for the work that you're doing so that you can get promoted. Making sure that you're getting career advice and sponsorship, again, creating communities, making sure that we train all of, not just the physicians, but the staff. I think one of the groups came up with that. And then getting the residents involved in solving some of our own solutions, not just doing it from the top, but getting the resident involvement so that they can come up with the solutions, be active in the engagement, creating diversity councils, and so on and so forth. And I think this is our last slide.
So just a summary for us is in terms of the retention and inclusion part is once we've attracted, more diversity within our workplaces, we really need to focus now our efforts on a systemic level as well as an individual level. And how do we make that inclusive? How do we support the people that we've been able to bring in and keep them here and learn from their perspectives and ultimately improve patient care? And when it comes from a systems level as well as from the ground up, that's where hopefully we'll be able to hear everyone's perspectives and take that into, more valuable feedback into how we're moving forward to improve our learning environment.
Great. So we'll pass it back. Thank you.
All right, so this is nearing the conclusion of the workshop this morning. Thank you all so much for attending and for participating. We want to remind you to do the post surveys that are on the table. The QR code for the post survey that you can just fill that out for us. That would really help us to continue sessions like these and also to learn and give us some feedback about how effective or not effective the sessions are. I wanted to give an opportunity in case anybody has any last minute questions. Feel free, you can ask them now, or you can also ask any of us after the workshop.
Do not forever hold your statements.
Yes.
Do you have any thoughts about, I think Dr. Smith brought it up earlier about instructors versus being called aggressive or assertive, how, I can imagine that there's many of these names that trigger a lot more emotions, and what are your thoughts?
You had mentioned this before, if you want to give your thoughts.
I think in general it's really challenging. I think like women, for example, I think we can relate to the idea of walking the line of aggressive versus assertive with what we say, and a lot of times we're actually saying it in a collaborative way, and all of a sudden we're considered very aggressive in that situation. And in some ways, for myself, I know I just own it. I'm just I know I'm being collaborative and so on, and just trying to ensure, but I do check myself, just read my own emotions and things like that to see if my temperature's up, then I'll be let's continue this in 5 minutes and take a break real quick and come back to that situation. But reading the room and the tension in the room can really help to figure out, is this escalating or de-escalating, right? Because the whole idea of addressing microaggressions is inviting people into the space. But if you're inviting them into a very aggressive and high tension room, they will not stay there. They will leave, and they will not take anything positive with them out of that. So, and it's okay I think something we didn't mention is that you can take a timeout, right? So part of that timeout is just, and I use this sometimes for my patients who have escalated and I need to restart with them, is, I see the tension is very high in this room, but I really want to serve you, and we want this to be collaborative. So I'm going to give us both 5 minutes to kind of regroup, and when we come back, we're going to start over again. Right, I'm going to address why you're here, and let's start over and actually focus on you. Right, so just giving everyone permission to go on a walk for a second and kind of regroup can make a big difference. But I think for women in general, I think, at our table, a lot of the time for the first scenario, we were let's go together to go see the patients. And I know that LA was not happy about with that, but our culture. Yeah, exactly. I think we should feel empowered, but we do know that there's gender stereotypes and also on gender bias that kind of play into how we respond culturally to different things, and just being mindful of that. And I think for women, especially in medicine, it's okay taking some ownership of being a little bit more assertive, knowing that I always think about what would my male colleagues do. That helps me. When I'm answering a situation to when I'm reflecting on myself, it's am I stepping out? If my male colleague did this, how would they be perceived? And if they would have been perceived normally, I'm not going to apologize for it, because that's not fair. I'm held to a different standard. So.
I also
also, just along that same vein, as someone who definitely is fairly comfortable with competition, I sought out mentorship fairly early in residency. I think when I started wondering if I'm being labeled a certain way, I think it was just really helpful to look for mentors who have had similar experiences and may have something to teach you. And also, a certain amount of self-awareness also goes a long way, because I think I asked very honest questions about what I could have done differently, and I was very open to taking that feedback from my mentors. And then typical situations, I mean, if I'm not really sure if I dealt with it very well, I'll often debrief it with people that I trust and go over it. Like, well, how could I have done this differently? And then kind of my last lesson, with patients, you can't really come back to them because the encounter's short, but if it's something with a colleague or administrator, if you're really, I think just think about where your emotion's coming from. Like, if you're responding only to react, then it's better to step away and maybe think about it for about a day or so, but respond within 2 days, right? And maybe if you're coming from a place of like, I didn't like how this went, but I really want to have this be a collaborative experience, and you feel like you're not angry, your temperature is not high, then I think it's okay to address it in the moment. But like, know that it's okay to step away and come back to it later.
We'll kind of wrap it up if that sounds good. So we hope, thank you, first of all, for coming. I think, you have a lot of different options at SAEM, even including just exploring Austin itself. So thank you all for just being part of our group and just allowing yourself to build networks and connections that we hope you'll carry out of this room itself. And shout out to little people in the world, because I love little kids. And so just really, I think it's important to realize that DEI work is relational work, right? We shouldn't be doing this alone. So as you're going back to your own institution, just know that you've created a network here that really kind of help you on that journey as you implement this, even if it's just clinically versus like institutionally or in your program itself, that if you need someone to tap on, that's why we had a lot of small groups kind of built into this. And then we hope we set the roots of kind of like a foundation for you, and also helped you kind of branch out of your comfort zone, which I know even for myself in facilitating these, it still is a stretch to kind of reach out and say, like, how can I grow and learn and receive the feedback that I'm getting on what is working and what's not working, so that I can become better at this. Because I think each time, each experience should be a learning point that will help us grow. Then we really hope that all of us have gained a new perspective, because I think that's really important. One is that there's no right way. We didn't teach this one tool. You heard from all of our speakers. There's multiple approaches to each of the situations, and just remember, each of you have your own talents and skills, and the way that you portray yourself that you need to take into account as you encounter these situations to be an upstander. And then the next is also just realize that we have a sounding board here. So while this work is challenging, if you have situations that kind of come up, just remember that you have a community to draw on, to be a sounding board on how to approach this, to kind of grow your institution as well. And then kind of the last thing is that we just hope that you feel empowered after this situation, that you are the change. I think just even being here, you should realize that there is people out there who don't realize microaggressions are happening at all. They don't even know that word. I've been surprised to hear as well. And so just even realizing that, acknowledging it, turning the lights on, if you will, for our community can be really empowering to really change the environment that we're teaching in, the care that we're giving our patients, the support that we're giving our staff, and also just calling all of us to be better for our communities itself. And in our goal, we know that diversity, equity, inclusion is really to bridge the healthcare disparities that are there. So together, by learning these skills and then sharing these skills outside of this room, that really is how we'll be able to do that together. So thank you guys, and we'll give you a couple minutes back, but we'll be around if you guys have any questions afterwards. Thanks.